Phacoemulsification in a case with phacodonesis. Now this is a cataract which is significant, and we can see the kind of cortical cataract, and it is an abnormal pattern somehow. When I started doing the rexes, I could see that the capsular bag, zonules, the whole complex was just not stable. So I decided that we will proceed with the phacoemulsification, but I was very careful in managing every possible step so that we could retain the bag and place the intraocular lens in the bag. So careful rexes was done, taking care that there was no increased stress on the zonules, and I also decided to do a complete hydrodissection and nucleus rotation to ensure that during phacoemulsification there is no stress on the zonules. Usually I don't do this step, but I thought that it will be better if I can separate the nucleus, cortex and the capsular attachments. Now we all know that cortical cataracts, it is known that they will have more stronger cortical and capsular attachments and adhesions. We started with the phacoemulsification, and it is not a very hard cataract, which in particular becomes a little more troublesome, because in significantly hard cataract which there is a formed nucleus, it is slightly easy because there is something to hold on to. Now these nucleus, which are more or less amorphous, they don't get aspirated, they don't get cracked, they just are a mass of lump of clay which simply gets detached from its original mass when you try to hold it and chop it. However, the nucleus was safely removed. Now this is the issue of removing the remaining cortex. Some small amount of nuclear material has been left behind, which I prefer to stuff or lacerate over the irrigation aspiration cannula, and this way you can remove a small amount of nuclear chunks, and this saves you time, because otherwise one may need to go ahead and exchange the irrigation aspiration cannula from the phaco cannula and then remove these chunks. Engaging each bit of cortex, and in between, when I am getting some solid chunk of tissue, I tend to lacerate it with the chopper in my dialer in my other hand. Cortex has been removed, and now we are all ready for implantation of the intraocular lens. Single piece hydrophobic monofocal intraocular lens from Appasamy Associates. Until now the bag is performing nicely. There is no zonular dehiscence or any vitreous prolapse. The bag appears stable till now. I'll also emphasize the trick here that I didn't need to dial it in the bag, because once the trailing haptic is coming out, one can simply tip down the injector tip and it will opens in the capsular bag. Now here this was a clear corneal opposite incision given to control the astigmatism. This is one of the best ways of controlling small amount of astigmatism due to corneal asymmetry. Viscoelastic has been removed. The surgery is finished, and we have this photograph showing one post-op day, and this is at 7 days. Thank you.